Good morning, my dear colleagues. It is very nice that we are approaching Ramadan, which is a very important days full of honors for all of us and full of merciful from Allah. And also, I am honored to start this lecture by presenting this in the early stage of generation of LRS 15. We are approaching to start admission for the new generation of LRS, and we honored to start this by an excellent presentation of our presidential international not guest speaker because he is a founder of LRS. 10 years ago, we start about 14 years ago the LRS, and the pre-LRS start in 2011. 5 years earlier than this, I met Professor Michael in Istanbul and start studying and preparing for our curriculum. And we consulted many of our friends all over the world until in 12/9, we start to do the early scratch in the LRS until it started in 2010. So I am honored to present the founder, one of the founders who paved the way for this long journey of LRS. I'm proud of being him with us today. I am honored to present him and honored also to ask my dear colleagues who support me in this journey in LRS 14. And on behalf of all national and international, Egyptian and international France LRS board, on behalf of them and by myself, celebrating this day. And thanks for Professor Michael Weber, and also ask all of my instructors, junior instructors, to start this by just few words to celebrate this occasion. تفضل دكتور عصام.
Assalamu alaikum. Good afternoon, Dr. Michael. How are you, our prof? It's my pleasure to introduce you and to welcome you in our this scientific day. Actually, I met with Dr. Weber many times in the deformity course in Dubai because I am working in UAE in Sharjah. That's why I met him several times. I'm really, all of you will get interested and enjoy it and get more benefits from this lecture today. Welcome, Dr. Weber.
Thank you.
It's welcome.
Mahmoud Mustafa.
Good morning, everyone. It's our pleasure to be here
Good morning, sir.
with us, our dear Prof. Michael Weber, and we will start now his first lecture. And now the speaker will go for our moderator.
Our moderator, as I mentioned for you before, Michael, that each day we have a moderator from the LRS trainee.
Okay.
So we have, as we discussed before, so we have this day moderated not by me or one of instructors, but one of the trainees themselves. Ready,
Okay.
Muhammad? Sharif?
Yes, Dr. Fadl.
تفضل.
Good morning, everyone. I'm so grateful for this great opportunity to introduce one of the pioneers, mentors, and a worldwide well-known expert in limb lengthening and limb reconstruction, Professor Michael Weber. So I will not delay him, and we'll start with the first lecture. I think it will be about Weber classification of tibial hemimelia. The mic with you, Dr. Michael.
Okay, I shall start.
Yes, okay.
Yes, please.
Okay, so good morning, everybody. And it's a pleasure for me to give some insight of my work. The LRS is a poor child of Mohammed, and I'm lucky that I could be part of it. And it's a very pleasure for me to present here to the audience some of my techniques. So we start first with the classification in tibial hemimelia. We did registration of congenital malformations of limbs in Germany, where we analyzed over 1 million live birds in order to find out what is the amount of malformations in Germany. This paper was done in the Aachen University, where I was working before. And we found, according to the tibial hemimelia, that there are 5 cases per year. So I had already collected 61, and this because I worked in before in a center for dysmelia. You know, all the Kondagan catastrophe in the 60s, where pain medication was used by pregnant women, and they had malformations of the limbs. And one of the center who found out this problem with the medication was in Heidelberg, and I had the advantage to work in Heidelberg, and was seeing about 60 patients with malformations a week. Yeah, so all my main knowledge and experience came from this time in Heidelberg. It was a great time at this hospital. At this time, had about 400 beds. Was one of the biggest orthopedic university hospitals. And later I went to Aachen, where I continued my work. So we analyzed these patients according to clinical data, radiographic data, and intraoperative data. And we checked the classifications available in the market according to their practicability, validity, the required correction of classifications by sonography, MRI, and intraoperative data. So I can make it short. All of these classifications available at this time were not useful for many reasons. The terms were not properly used, and a lot of types were missing. And the only good classification was from Henko, 1978. But this classification was designed more for scientific studies, because it was detecting everything what was malformed, and this is not usable in our clinical practice. So then I came up here with my own classification, and I still have here all these let me see what happened when I click here. I don't click. Okay. Somehow the pictures are obstructing my view. If you somehow can leave your picture so I can see my own presentation. Okay, so the classification came out in 2008. There are 7 different types. Type 1 is hypoplasia. That means only the tibia is there, but only a little bit smaller as usual. Type 2 is a diastasis. Diastasis means that the foot is between fibula and tibia. And then the distal aplasia, that means that the distal part of the tibia is not correct. And starting from type 3 till type 7, there are 2 different forms for each type, one with a cartilaginous Anlage and one without a cartilaginous Anlage. I will come to this difference later. Then the type 4 is a proximal aplasia. Type 5 is a bifocal aplasia, means proximal and distal aplasia of the tibia. The mid is there. Then a type 6, which is lack of the tibia with double fibula. And type 7, the most severe form, is a single fibula and lack of the tibia. So from type 1 to type 7, the severity of the malformation increases, and therefore also the amount of surgeries you have to do. So these are the type A with cartilaginous Anlage. Each of these types, except type 1, type 2, can have that. The others are those without. This has a severe impact on the treatment concept, if there is a cartilaginous Anlage or not. So this is the analyzation of the different types. You can see of this clientele at this time. This were over 90 limbs. Meanwhile, I have treated over 200. You see here, the most of the cases, the most severe form. Yeah, and you have to deal with this one. And what is quite often is also 3B, means without cartilage, and 7A with cartilage. So you see, this is the distribution of the different types. What is very important to know is that the severity of the different types is also depending on if there is a cartilaginous Anlage or not. So in general, from 1 to 7, it's increasing the severity in both types. But here, with cartilaginous Anlage, these types are much more advantageous because you can do a lot of good things with this cartilaginous Anlage. So far, you detected it. This is a different story. So, for example, type 3 with cartilage, it is much better, is a whole class better than a type 3 without cartilage. This is what I want to show with this picture. Let me close this. Okay. So, and here's a comparison of the different classifications up to now. All the white area here in this table means that the other authors don't have a type like this. You see my types here from 1 to 7, A and B. And you see here in Jones a lot of white. You see here with Kalamshi a lot of white. And you see a lot of white in the Paley classification. Also, he has modified it after I came out with my classification already 3 times. But still, a lot of cases are not existing for Paley. So let's go over these hieroglyphics of the classification and come to the summary. So all these classifications, from my point of view, are not useful. And my classification is precise, and the terminology use the pathologic anatomic terms correctly. It's a comprehension of the different forms in a logic sequence of the longitudinal reduction deficiency of the tibia. So I will show it also later. What does this mean? It means that the main types in the reduction deformity of the tibial hemimelia are included. There are no others. And my classification doesn't use symptoms of the disease. For example, the position of the foot is a symptom. Yeah? Or if the leg is big or small, it's a symptom, and this is normal. Okay, so to make a new type out of this doesn't make sense. So it shows also the sequence of the severity, and this is the main reason why I designed this classification, is I want to have therapeutical consequences according to each of the different forms. So the conditions for adequate therapy, you need a good classification. You have it now. And a detection of additional malformations on the affected limb, because it has a consequence for the treatment, according to the joint, the femur and foot, and the muscle function. Therefore, I designed also a score system. So the score system shows here, there's the hip, there's the femur, there's the patella. Patella plays a great role in construction of the leg, in complete missing of the tibia. And here the different forms of the tibia, the fibula is important, and the foot as well. And here for the muscle function of around the hip, around the femur, and around the tibia. Okay, and each of them got a point. And what's also important to see is that each different type differs in certain increase or decrease of the points. So every I'm still fighting here with this with this picture. It's not going away. It obstructs my view here. Nevertheless, every anatomical region is represented. Hip, femur, fibula, foot gets maximal 2 points. The patella get 3 points because of the importance. A muscle function, 3 different types, maximum 2 points. Tibia is divided in the 12 types, with and without cartilage. The point difference between adjacent types is 2 points. And the point difference between having a cartilaginous Anlage or having no cartilaginous Anlage is 10 points. And this shows you the importance to detect if there is a cartilaginous Anlage or not, because you can do very good things with it. And this is the score. So maximum 39 points, minimum 0 points. The grouping differentiate 5 different classes. Every 7 points, the class change into the next one. Inside the class are 3 levels, and the level is +1 and -1. And the classes increases according to the severity of the disease. Means class 1 is not so severe. Class 5 is the most severe form. Okay, let's talk about the universality of my classification. So there are 12 different types. And let's see how universal these types are. So, for example, the type 1 can occur in different sizes. Yeah. Other authors might say this is a different type as this one, but it isn't. It's only different in size. The pathologic anatomical disturbance is for all of them the same. It's a hypoplasia. Okay. So the next point is that the relation between the shortening of the tibia to the fibula can be different. So again, same tibio-fibula relation, and here a different tibio-fibular relation. So you can have different sizes here, and you can have different sizes in the relation of the hypoplastic tibia to the fibula. All of this is hypoplasia. Okay, so none of them will be honored of these forms to be your own type. Doesn't make sense. So also type 1, the hypoplasia can occur in different sizes and in different tibio-fibular relations. Let's see some cases here. This is a hypoplasia. This is a case with hypoplasia. And you see here in the score system, class 1, this is the best class. So it's very easy to treat. Okay. Type 2, diastasis. The foot can be in different levels between the fibula and tibia. These are no different forms. It's all the same. the diastasis of the tibiofibular relation. So you see it here, and this is also class 1, because this can be treated as well very easily and with extreme good functional outcome. Let's check the distal aplasia. The distal defect can have different lengths. So when you have a case, it must not look like this one or like this one. Important is that the defect is distally. And this can be very short, like here, or in the type A till here. All these different lengths occur in the literature, occur in cases I have, and so on. But they are the same types. It's the same type 3. So you see already that this is a comprehension of the main deformity reason. Okay. So, and here still class 1, because with cartilaginous Anlage. You will see later in the presentation what I'm doing with this one and why it still has a good score. Without cartilaginous Anlage, now we are already from class 1 to class 2 minus. So this has a huge impact on the treatability, and you have to do much more surgery in order to get a good function. The type 4 proximal aplasia, and the same. You can have different proximal amount of defect, but it's still the same. It's a proximal aplasia of the tibia. And here's a case like this, still type 2, class 2. So it's not so bad because it's a cartilaginous Anlage. With this, we can do a lot. And it's a class 4, so 2 classes down because there's no cartilaginous Anlage. This is the type 4B. And for example, here, Paley, Kalamshi, Jones, they don't have this case. They don't have this type. Also, it's very important. So bifocal aplasia. So the bifocal defect can have different lengths as well. Can get short like this, or can get short like that. It's all the same. It's a bifocal aplasia of the tibia. Here without cartilaginous Anlage, and you see here, this is type 5. It's very difficult to treat. And with cartilaginous Anlage, look at this. You have class 2. So you must be excited to see what we can do with the cartilaginous Anlage in order to get such a good score. Type 6 is total lack of the tibia with double fibula. It's very rare. Also, the tibial hemimelia is already very rare with 1 per 1 million live births. The double fibula is even more rarer. So, and the residual cartilaginous Anlage of the tibial Anlage can also have different sizes. Okay. So here this is a case, and this is 3+. So not so bad at all, the score. And the score here for the without cartilaginous Anlage is much worse. Okay. We had this already. So then you can have this type with patella, yeah, and without patella. With patella is class 4, total lack of the tibia, and without is class 5. So only the fact that there is a patella gives a huge impact on the score. This is a much better situation to have the patella. Why? Because this classification is made for surgeons, okay? With the patella, you can do very good things, and I come to this later. So let's have a look to the type 3 and to the type 4A and type 7A. Because here, this is the only time where I have a little bit, let's say, not very crystal clear terminology. And I did this on purpose, because Agenesia means there is no tibia. But if you look at this, there is a tibia in form of a cartilage. So why did I do that? So here we have these three together. All of them are distal aplasia. This one is distal aplasia, this one is distal aplasia, this one is distal aplasia, this one is distal aplasia. But these two here in the middle, I call them agenesia, means total lack. So why did I do that? There is no bony tibial joint partner. It's number one. Number two, the quality of this cartilaginous Anlage seems to be much less than in all other types. And the treatment of these types is much more difficult than the simple treatment with the type 3, which you see here. It is questionable if this cartilaginous Anlage can be used, and I sacrificed the correct terminology in these two types for a better practicability in terms of therapy and not to disturb the sequence of the different severities of the different types. This is the reason. I was thinking many days about this, if I should do it or if I should make the classification more complicated. I think the explanation is clear. Okay. The universality of the Weber classification means that all main different types of the tibial hemimelia are included, as well as the multiple degrees of expression of each type. So, advantages, a lot of advantages. And the main important part of the classification is made for surgeons. And this leads to therapeutical consequences. So it's not new anymore. It was done in 2008. This classification and score for tibial hemimelia is a simple, therapeutically relevant classification with the main different types, including their different degrees of expression, representing the pathology of the preaxial longitudinal reduction deficiency, respect the importance of the cartilaginous Anlage. Most of the authors don't do that, and gives a scientific comparison of the different pattern of defects between different authors with the score system. So this is published in two books in 2007 and 2015. Thank you very much for your attention.
Thank you very much, sir, for your excellent.
Questions?
Thank you, Professor Weber. Any one of our colleagues has a question for Professor Weber?
Excellent as usual, Michael.
Thank you.
Thank you so much. Any question from our colleagues?
Yes,
I think
please,
they
Professor
are-
Dr. Fadel.
Huh?
Yes, please, Dr. Fadel.
Yes, please introduce yourself, and Dr. Sharif will control the questions, please. تفضل.
I am Ahmed Hashim, number 13.
Okay, Dr. Ahmed, go on.
Please, Dr. Michael.
Yes.
You are welcome, and thank you for this topic and for this classification. It's mainly useful. And my question about the bifocal tibial defect.
Yeah,
About the proximal and distal defect.
yes.
How the tibia is formed or its growth. My question about this defect. How can it be formed?
You mean this one, right?
Yeah.
And your question is how it can be formed?
Yeah.
Formed or reconstructed?
You mean reconstruct or constructed?
I'm not asking about the reconstruction. I'm asking about about this defect, the proximal and distal defects.
Yes.
The tibia, in my imagination, is a proximal and distal,
Okay.
and it
Let
comes
me
from
explain
proximal.
And let me explain it again. So this from here to here is the tibia, the rest of the tibia. This from here to here, you can see the arrow?
Yeah.
Okay, this is tibia. This one is without cartilaginous Anlage, and this one is with cartilaginous Anlage. So
Yeah.
there is a tibial defect here, and there's a tibial defect here. There's a tibial defect here, and the tibial defect here. This is part of the damage of the embryological development.
Yeah. I'm asking about the type without cartilaginous, without a cartilaginous leg.
Yes, this is this one here.
Yeah.
And what is the
Sorry, Dr. Michael, he's asking about how it is developed from the beginning. I think this is the question, Dr. Ahmad.
Yeah.
Yeah, this is actually a good question. You mean if there is no cartilage, how can there be bone at the end?
Yes.
Yep.
How did it grow?
Yeah, this is a good question. Yeah, so it can be that at the certain time of development, yeah, there is a damage to the growth plates proximally and distally. So that only a certain amount of tibia has developed and the rest is obliterated, you know? So this could be a reason. But for each case, we don't know. We only can registrate that these types occur.
About the bifocal defect with cartilage, a leg, I can imagine it. But without a cartilage, these areas, proximal and distally, what can fill it?
Okay, you know the dysmelic patients which were arisen from the Kondagan disaster in the 60s. They, as I said, these are women who took a medication when they could not sleep, and the pharma product was announced that they can take it even when they are pregnant. And this medication lead to longitudinal reduction deficiencies and also to transversal deficiencies by damage of the growth bud of the extremities. And you can have any type. You can have pre-axial type, you can have an axial and a post-axial type. So you can have a fibular hemimelia, a tibial hemimelia, or both, or whatsoever. It depends when this medication reached the body and the fetus at the certain time of development. This is one of explanation which I have, but the reasons for damaging of a development can be multiple.
So it's time dependent.
It's what?
Time dependent.
Of
age
course.
dependent.
It's age dependent, and if there is a toxin involved, or even certain genetic problems, we know that some of the tibial hemimelia, especially those with cleft feet and cleft hand, they have inheritance and so on. So this is also depending on the certain amount of gene expression.
Okay, Dr. Michael, many thanks for you.
You're welcome. Good question.
Thank you.
Assalamu alaikum. Assalamu alaikum.
Walaikum assalam.
Good morning, Dr. Michael.
Good morning.
And thank you about your presentation and simplified classification, really. My name Dr. Huma Yahya, trainee number 29. My question about the type 2 in your classification. You mentioned the foods may be located in many different levels. Do you have any subtype classification for this type of distal diastasis?
Yeah. My intention to make a classification is to make a classification very comprehensive and not too complicated. Okay. So that's why I showed you here that it's, from my point of view, not important if the foot is here, if it's here, or if it's here, and if the foot is in clubfoot position or valgus position. These are all details which are depending on how the fetus was lying in the womb and where did the foot get the pressure from. Yeah, the main pathologic anatomical problem is the diastasis. Yeah, and all the others forms you can see with this are only expression of the same problem: diastasis between tibia and fibula. And if the foot is here, 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 or here, if the foot is turned, or if the foot is in valgus or varus, for me, this is not an issue, can be treated the same way, only that you have to correct these additional deformities. But it doesn't make sense, from my point of view, to give more subtypes. Doesn't make sense. Yeah. Otherwise, then you have not 12 different types for the classification. You have 50 or 100.
Okay, with the same functional outcome?
Yes. Yes.
Even so, up or in the middle part, or in the lower part.
The only difference between this one wide up and this one wide, the one wide down, or at the beginning, is that you have to distract the foot a little bit longer. That's all.
Okay. Thank you, sir. Thank you.
Thank you, Dr. Arhuma. Okay, Dr. Muhammad Aid has a question for Professor Michael. Go on, Dr. Muhammad.
Good morning, our dear Prof, and good morning, everybody. I want to just ask about in case of proximal tibial aplasia and the role of patella. Is there sub-classification for patella, or we should treat it as whole extensor mechanism? If the patient have multiple deformities, or it is a CB patient with spastic disorder.
Just looking for the picture. Here we have it. By the way, I hear you, everybody of you has a number. My number is 007. The license to cut into patients. So this where you're talking about? You are,
yes, sir.
Asking about the proximal aplasia and if there's an extensor apparatus or not. Correct?
Correct, Prof.
Okay. So in this type here, there is an extensor apparatus, yeah, but it's also in a certain way insufficient. Yeah. So this is number one. Here, you can have an extensor apparatus, or there is a lack of extensor apparatus. So then what you have to do anyways, and this is the much more difficult case, you have to create a joint with an extensor apparatus. Okay, here you can use this, what is already there, and most of them have a patella. Here it could be that they don't have a patella, and then you have to construct extensor apparatus. But I will show it to you later in the presentation of the treatments. Okay.
Okay, thank you, Prof. But what if the patella is present but muscles, extensor muscles is spastic? Is that considered subtype or
No.
just?
When you have a patella, usually you have also a quadriceps tendon and muscles for it. Okay? Only if the patella is missing, you can have also missing quadriceps tendon and hypoplastic quadriceps muscle. But if there is a patella, you have everything there.
What is that mechanism?
The extensor mechanism, except the ligamentum patellae.
Okay, thank you, bro.
Is it clear?
Clear, bro. Thank you.
Okay, welcome.
Okay, Dr. Abdullah Suwaidan has a question for Professor Michael.
Yeah, yes, I have one question. I'm trainee number 3, Abdullah Suwaidan. I would like to ask Prof. Michael. We know about tibia hemimelia, it's rare, and when it present, most of cases managed with end with amputation. According to your experience, and most of your cases end with same management with amputation, or you do reconstruction for them?
I can give you right away an answer, but I would like to postpone it to the next presentations where I show you how to treat it. The direct answer is I have not done a single amputation in all of my cases.
Very nice.
Okay.
Thank you, Prof. Thank you. We would like to hear this one only. Because we know it is difficult when tibia hemimelia is present. It is difficult to manage, and it is demanding and need long time of follow-up and centralization with soft tissue release, and from my opinion, it's difficult. But your experience, we'd like to hear your management of your cases. Thank you, Prof.
You will see in the next lecture. I think all of you hurry to know the management, but with the hand of Dr. Weber, you will see the difference.
شكرا حاضرين شكرا.
اوكي دكتور علاء محمود. Dr. Alaa, you have a question for Professor Michael? Okay, we can go. Dr. Vidya has a question for Professor Michael. Go on, Dr. Vidya.
Sir, thanks a lot, first of all, for excellent presentation. This classification is for tibial hemimelia. This also applied for phocomelia, which occur due to thalidomide intoxication.
Only in case if there is a tibial hemimelia, if there is longitudinal reduction and deficiency from the tibial type. Yeah, in thalidomide embryopathy, as you have talking about, usually there are more parts of the extremity involved. Yeah, so this is then different.
Just my query, sir, is it still we can see phocomelia like symptoms is still presenting in clinical scenario?
The thalidomide embryopathy?
Yes.
Yeah, these patients are now 60 years old. So you are not bothered with any reconstruction or construction. This is finished. Yeah. So the main age is as early as possible after the birth. and this usually around 12 months. Then you can do the most of the techniques. Once they are adult, you only can do some symptomatic surgeries and some braces or prosthetic fittings.
Thank you. Okay.
Okay, last question. Last
Okay.
question from Dr. Abdulaziz Falah.
Morning, Professor. Good morning, everyone.
Good morning. What is your number?
27, Professor. My name is
27. 007 is answering you.
Yeah.
Professor
Regarding the
Michael
TBL,
Bond, I think.
can we detect it while the child is still in fetus? And can we do any preventive measures or anything to decrease the severity?
Okay. Number one, it can be detected intrauterine by a sonographer who is familiar with malformations. There are, meanwhile, even in Dubai, obstetricians who are specialized in fetal pathology. Yeah. And I had already patients who were referred to me while they were pregnant, and I gave them explanation what they have to expect after the baby is born. Number two, answer on their question, we cannot do anything while during the pregnancy because you hardly can apply a ring fixator inside of the uterus, okay?
Yes, of course. Okay, Professor. Thank you.
Okay. Interestingly, you need to be really, as an obstetrician, as a gynecologist, you need to be familiar with these malformations. We did a study in Heidelberg of all our cases retrospectively, how much of these partially very severe defects with completely missing of limbs were detected by ultrasound. In all of the cases, ultrasound were done, and only, and this I'm talking about Germany, only 5% of them were detected. Even so, they were presented in centers for sonography diagnostic. So at this time, I'm talking about, let's say, 30 years ago, they were not so good. But meanwhile, here in Dubai, we have specialists who are very, very experienced. Okay.
Yes.
Okay, Dr.
Okay.
Michael, but excuse me, the last questions from Dr. Ali Muhammad Tayyab,
Mm-hmm.
Good morning.
number 3.
Thank you so much, Prof. Weber. I have one last question. In your classification, you're focused in the tibia alone, and if there is any anomaly in the other part than the tibia, I mean femur, upper limb, is not included in the classification.
Correct.
Just think.
That's why it's called classification of the tibial hemimelia and not of the whole leg. This is also a point to make it very simple, okay? And in the score system, you have also the functions of the other, of the rest of the limb, but only also not very detailed, only very, in a way, included as it has a consequence for the treatment. But for example, if you have a femur with a double femoral condyle or additional bone in the mid of the femur or whatsoever, there are so many different parts which can be involved. This is a different additional malformation which you have to address. For example, if you have in any case where you have something additional, you should think how you can use this additional anatomical substrate to use it for the tibial hemimelia. For example, you can use cartilage and make a patella out of it, or you can, this is what I call transformation surgery, okay? Or maybe if you don't have a tibial plateau or knee joint, maybe you can use one of these additional condyles to do something like that. You know, you can improve the function greatly. Yeah, but to include all the possible malformations which are occurring in combination with tibial hemimelia, then you have to put the cleft foot, the cleft hand, all the different types of those, the malformations of the femur. This won't lead to practical classification in tibial hemimelia.
Thank you so much, Doctor. Thank you.
Welcome, welcome. So we shall go to the next presentation.
Yes, please, our prof.
I think if we open for more discussion, we will have, but it
No
is
problem.
reasonable to it is reasonable now to start again. We just finished around 20 minutes for questions. It is a lot of questions. Thank you so much.
No problem, no problem.
Excellent. We are in need for this question to declare some of beyond our understanding of my colleagues.
Okay, let's start about one of important treatment in tibial hemimelia, which I call booster surgery. You will see soon what I mean with booster. It belongs to the cartilaginous Anlage. Okay, so before we talk about reconstruction, or what we do in, or what I'm doing in the tibial hemimelia is not a reconstruction, it's a construction. So I build things which were not there before. Reconstruction means when you have a trauma and the bones are broken and you reconstruct them. Yeah. So that's why I'm calling it construction of a lower limb, and you will see why. So what are the alternatives here? This is an alternative, of course. This is orthopedic orthoprosthesis. Yeah. But let's have a look. Or this one. Yeah. These are. You don't have any other possibilities to improve the life of these children here in this transversal reduction defect as to give them these things. But I think we can do better. You want to see what this guy has to show you?
Yes, yes.
Okay, then I have to open it extra because we were fighting together with your technician to get it done, but we were happy that, here it is, that we could start my presentation. So I hope I can bring them here and make it a little bit bigger. So let's see what this guy has to offer.
Listen to me very carefully.
Yeah, actually, the visitors, they were very afraid of this hand. I would love to have equipment like this. Then we would have another great option how we can solve limb problems. Yeah, but unfortunately, this is only reality in Hollywood, and therefore, orthotics are still very important, but we can do better. And in my opinion, the natural limb is best, and I like to show you my techniques accordingly. What we need, first of all, is growth. This is important in all of the cases. And for this, you need to know the biological principles. I can make this quickly because you are part of this LRS program, and you know that the natural growth comes from the growth plates. That's why small genes become bigger genes. And we can do artificial growth by corticotomy and callus destruction. So, and this callus destruction has a lot of positive effects. Not only we get new bone, we get new vessels. All the soft tissue involved is growing. So not only the bones, the nerves, the muscles, the tendon, the skins, everything is growing. And you need hardware. Which one? I prefer rings. Not this one, but the Elizarov ring, which I still use. And I think in Egypt is also very popular. This is myself here with Elizarov. I visited him in 1990. It was super interesting in Kurgan. And I spent also his birthday, his 70th birthday with him. He was very interesting, a smart guy. And this is Taylor. He came with in 98. He launched the TSF and met him, of course. And I'm using also a lot of TSF. And of course, for deformity correction, you can use in childhood 8 plates. So let's talk about the booster surgery. What is booster surgery in tibial hemimelia? All these cases with cartilaginous Anlage, they enable booster surgery. And this is a breakthrough in joint construction. Memorize this slide. It's a breakthrough in joint construction. You will see why. So this extraordinary finding enables the booster surgery. And what is the booster surgery? Is an enhancement of the sleeping growth potential of the cartilaginous Anlage. So let's start with this case. This is a distal aplasia with cartilaginous Anlage. So this is the MRI of it. You see here, if you do an MRI, have the possibility give contrast, then you will see it more clearer. But here is the cartilaginous Anlage. Yeah, and most of the surgeons worldwide ignore this and resect it and give up a huge possibility to improve the function. And this is what you usually see. In the X-ray, you don't see any cartilage. You see only proximal tibia. There's a defect. Here, this is the bowed fibula. And what happened here? This is after 5 years, it looked like this. After another 2 years, it looked like that. What is the reason for this maturation? Yeah. Would you expect that this happened naturally? What is the natural development? The natural development of a leg like this is that. Yeah, you have your fibula still bowed. The fibula becomes more thicker, becomes hyperplastic because the patient, the child, is walking on it. And here at the tibia, there is no contact. So the rest of the cartilaginous Anlage will, and the rest of the tibia will atrophy, because it's not under weight load. And what is not under weight load, what is not used in the human body, it get vanished. Okay. So what is the reason for this maturation? The reason is I have done something, and it's very simple. For people like you, LRS team, they can do it very easily. Here, this is the cartilaginous Anlage. Here is a gap. Sometimes there is a gap, sometimes not, but for sure a shortening. And then you only have to cut the bone, and you do the lengthening in the typical way with your fixators, and then you end up like this. And not only because you bring the cartilage of the distal tibia in contact with the talus, you will bring it to weight load. You will even get epiphyseal growth plate. There are two reasons why you get such a great maturation of the cartilaginous Anlage. Number one, the callus destruction itself, as you know, enhance all growth factors in your body to make growing possible. And due to the fact that the patient can walk on it, this leads to a nearly normal tibia. So what happened to the fibula? I didn't do nothing to the fibula. Automatically, by the self-correction of the soft tissue stress, the fibula straightened out by itself. Okay, this is the patient. On the right side, I have done something else. You will see what I have done on the right side. They get orthesis, and after removal of the fixator, he was able, I think this 2.5 years after the surgery, able to play soccer. Now we come to the bifocal. There was also a question from the audience. Bifocal tibial hemimelia with cartilaginous Anlage. You see, here is no gap. Here is no gap. This is the tibia with the cartilaginous Anlage, but in comparison to the other side, yeah, it's a huge reduction of the length. So what you have to do, and you see here still class 2. Class 1 is the best class. Class 2 is one class more severe, but you will see what can be done. So the same principle, if there's a gap or not, you cut the bone here in the middle, do the docking on both sides, put it into contact, and then you get this bifocal, from this bifocal bone transport, proximal and distally, a wonderful regenerate with epiphyseal growth plates. Here the clinical picture. This is a mini fixator, by the way. So you see, I start as soon as possible, very early. And the smallest chisel to cut the bone here, I could use to do the osteotomy. This is the fixator. Here you see, I didn't have a smaller chisel, so the bone need to have the, when you ask me, and this might be a question, when do you start the treatment? Usually with 12 months, but as soon as I can put my equipment on and can start it. So the limiting factor here is to make a fixation of the small bony part of the tibia and do a cut. Yeah, as soon as I can do that, I do the surgery. Here the fixator. Oops. And here you see the difference. Here is very small. Here you see already the bifocal transport. And this is, these distractors are needed to do a lengthening of the whole leg to equalize the shortening of the whole lower leg. What is very important is that you have to control the bone transport, that you don't over-lengthen it, and you compress the cartilaginous Anlage to the joint partner. So you measure the distance of the transport to be made, and then at this time you do an arthrography to check, as you have seen here, the ankle joint, to check that you have docked. Don't go further because you can damage the cartilage. So at this level, I stopped it, yeah, and waited for the further maturation, which you see here. You see still the fibula is a little bit in overlength, yeah, but he will have, this child will have, it's a girl, another lengthening. You don't need to do everything at once, okay? It depends also a little bit on the local situation and not to overdo it. Yeah, you don't want to have a cutout of the wires through the small bone piece. So more you go into the destruction, so more stress you do to the transported bone segment, and it's better to stop at the right time in order not to get a complication. Okay, here, and this is the second lengthening as I promised. And you see here also, Here we started, and this is where we end up. So we have the same leg lengths as on nearly the same leg lengths as on the other side. And these are the two lengthenings, AP and lateral pictures. We started from this bone, ended with this bone, with epiphyseal zones on both ends. Yeah, here you can see it better. There's also, so with two lengthenings, I did the lengthening of the segment of 400%. Normally you can't do this. Number one, you can do it only in children, and number two, only if you do in these cases where there is the leg waiting for a lengthening. So the Weber booster surgery create joints. There's a construction, knee and ankle. The cartilaginous Anlage produces a tibial plateau or a tibial ankle part. The maturation of the cartilaginous Anlage with the development of an epiphyseal growth plate is the effect of growth stimulation due to the callus destruction, growth stimulation due to the weight load. With other words, form follows function. Give the cartilaginous Anlage the function it should have, then it automatically forms the adequate form. So once the cartilaginous Anlage is in contact with the joint, it becomes a joint partner and it starts growing on itself. Is also very important. So not too many lengthenings have to be done to equalize it over the whole growth period. So my recommendation, custom-made analysis, use modern techniques like ultrasound and MRI. All my patients with tibial hemimelia, I put into sleep and do an MRI, because I don't want to miss the cartilaginous Anlage, and you need it also for checking how much quadriceps is there extensor apparatus, is there patella, and so on. And of course, you can use also your intraoperative view for analyzing the biological resources and use the biological resources to create better functions. Another point, so earlier the operation, so better the adaptive processes and the functional results. A lot of patients who come to me were told they should wait until the patient is bigger, and some crazy comments from other doctors were that it can heal by itself. This is of course not possible, and so longer you wait, so less the outcome of your construction. So to have a good functional outcome, you need all these people on board. This is not only a problem of surgery, you need all these people on board to have it. I published the tibial hemimelia and also pseudarthrosis of the tibia in these two books. You can read it there. Thank you for your attention.
Thank you so much, Dr. Weber. Thank you.
Thank you, Dr. Michael. Any question?
Assalamu alaikum. Assalamu alaikum.
Alaikum assalam wa rahmatullah.
Alaikum salam.
Good morning, everyone, professors and colleagues, and I hope you all are doing well. Thank you, Professor Michael, for this incredible, informative lecture. And it's an honor and it's a good opportunity to be with us. Sir, I have 3 questions. First question is the knee. The knee is so critical in management of these kinds of limb deformities. So as one of my colleagues mentioned about the patella, what if the patella is missing and to your long medical journey experience, what do you suggest to do? And how would that affect the extensor mechanism later on? Because some of these cases may complicate it with knee stiffness or arthritis knee. Second question is
Let me ask the first question. 1 second.
Go on, sir. Go on.
Before you get confused, answer the first question. If the extensor mechanism, patella is missing, usually also the extensor mechanism and extensor apparatus of the quadriceps is missing, more or less. What you can do is you can, if the extensor apparatus is still there and you have a connection to the quadriceps tendon, you can make a free transplant you can use local tensor fasciae latae fascia to reconstruct it in the form that you go over the knee joint and insert it into the tibia. Okay, so you produce extensor apparatus with or without patella connection to the tibia. Okay, how to make a patella? You can make a patella if you have additional substances, substrates, which you don't need. I mentioned it earlier with some of them have additional condyle or whatsoever. You can use this, or if you don't have that, you can make a patella out of the iliac crest. Iliac crest has apophysis. You make your extensor apparatus, and then above the condyle, at the position where normally the patella is, you insert the round piece of free iliac crest transplant, put the apophysis towards the cartilage of the condyle, and attach the bone part and the fascia around it to the extensor apparatus. This is a possibility. If there is no extensor apparatus at all, you can give it a try if there is enough muscle to do the same thing, but then you have to construct the whole extensor apparatus. You have to you have to attach the tendon transplant to the rest of the muscle. Detach the muscle from the femoral bone and make the transplanted tendon surrounding it at the end. Okay? And then you have to hope that it will get fusioned to the muscle. And then with the time, it could be that you get you can get functioning extensor apparatus. I have a case like this, and was working very nicely.
Okay, sir. That would leads us to the next question. When would you like to raise the level of the iliac frame above the knee? In which circumstances, sir?
Usually in all of my cases, I transfix the knee joint.
In most of the cases?
In all of them. Because
all of them.
Because, and even if I do simple lengthening of the, if it's not a tibial hemimelia, if you do a lengthening, you're always at risk to get subluxation or luxation of the knee joint. So I temporarily apply an isometric hinge. You can do it with normal hinges. I have a special hinge for that. And during the lengthening process, I even lock the knee after 5 millimeters of distraction. And then afterwards, I only remove the locking and do the exercises. Has the positive effect that the patient has no pain and no stress with the physiotherapy during the lengthening. And the lengthening is more sufficient because all the length force goes into lengthening of the leg and not into flexing of the knee joint.
Okay, sir. Third question, please. What kind of physiotherapy and rehabilitation protocol would you recommend post-operatively, sir?
For each patient individual, there is There is not such a thing that you can say each patient is the same and that there's a program. What I do in general is I want the child to walk as soon as possible. Yeah, I have children who had bilateral fixators on both legs till to the femur, yeah, and they were walking after 2 weeks. Once these children got to know that they can walk with the fixator, they do it. You can't stop them anymore. They won't sit in the wheelchair or lying in bed. They want to walk. And this is your advantage, okay? Use this advantage. Children are very happy to be active, okay? And what has to be done with the physiotherapy, of course, is once you do, and we come to this later, a knee construction or something like that, then you need the physiotherapy to do the range of motion for the knee, which is not so, which is painful for the child. This is not so funny. I usually combine it with epidural anesthesia, especially in the first week.
Yeah, sir, it's so clear. I think these dealing with the deformity correction in children is something so critical, and I think it's a miracle for this little child to get back after surgery. Otherwise, the surgeon himself would make him suffering for the rest of his life. So thank you for this information, sir. I appreciate it.
Dr. Sitti, number 23.
Yes, thank you so much, moderator, for this chance, and good morning, everyone. I want to thank firstly Professor Michael for this very informative presentation, and also I am so proud because today I see him face to face, like virtual, and I read a lot of about his studies and books. Professor, I want to ask one question regarding to I read before you have a study about the intrauterine stimulation of cartilaginous formation. How to do like this, and what about the outcome? And thank you so much.
Can you ask the question again? It was some disturbance in the voice. What is your question?
Yes, yes, sir. Just I read before you have some study, you discover some way to do intrauterine for the fetus stimulation of cartilaginous formation.
No. It's a misunderstanding.
Yeah.
It's a misunderstanding. I don't do any treatment intrauterine.
Yes. Thank you, sir. Thank you.
Welcome.
But as general, there is no rule for this management, or
not that I know.
They not discover like this.
Not yet.
Okay, thank you.
If you find the gene of salamander, I don't know what is the English word for it. These are these animals who can lose a tail, and the tail is growing back. If you find
Salamander.
Salamander, yes.
This would be salamander. Yeah, this would be great, but it's not found yet.
Yeah. Thank you, sir.
Muhammad Eid, number 10.
Good morning, sir, and
Good
thank you
morning.
for your precious presentation. My question is there any rule for using a fibula in the treatment as a bone graft or as a reconstruction method?
There's a lot of rules, and I show it in the next presentation.
Thanks, sir.
Okay.
Okay, thanks, Dr. Michael. We can continue with lectures.
Okay.